Bismillahirrahmanirrahim. Today we are going to start with the CVS sessions. Let's get straight into it. So we'll start with the CVS embryology. So in the CVS embryology, just give me a second. The embryonic structures which are given in this picture will give rise to certain structure in the adult life. We'll see them first in the picture. So on the left side here, you can see that we have truncus arteriosus, bulbus cordis, primitive ventricles, primitive atrium, and the sinus venosus. So now let's see one by one that what these structures are giving rise to in the adult form. The truncus arteriosus will give rise to aorta and pulmonary artery. This is the common truncus arteriosus, which will give rise to aorta and pulmonary artery. Then bulbus cordis is going to give rise to smooth left and right ventricles. The primitive ventricle will give rise to trabeculated left ventricle and right ventricle. Okay, and primitive atrium will give the trabeculated atria. So remember that the primitive atrium and ventricle will give the trabeculated part of the ventricles or atria, and the bulbus cordis is giving the smooth part of the left ventricle and the right ventricle. Then we have the sinus venosus, which will give rise to right atrium and the coronary sinus. Okay, so the truncus arteriosus gives rise to ascending aorta and the pulmonary trunk. The bulbus cordis gives rise to smooth part, outflow tract of the left and right ventricles. The primitive ventricle, trabeculated part of left and right ventricle. The primitive atrium will give rise to trabeculated part of left and right atrium. The primitive pulmonary vein will give rise to the smooth part of the left atrium. Okay, the smooth part of the left atrium is coming from the primitive pulmonary vein. Left horn of the sinus venosus will give coronary sinus, and the right horn of sinus venosus will give the smooth part of the right atrium, that is sinus venerum. Okay, so smooth part of the left ventricles is coming from the bulbus cordis. Smooth part of the right atrium is coming. The right atrium is coming from the smooth part of smooth part of right atrium is coming from the right horn of sinus venosus, while the smooth part of left atrium is coming from the primitive pulmonary vein. Got it? The trabeculated part of right and left ventricles are coming from the primitive ventricle and atria. Okay. Now we have primordial atrium over here. These are left and right horns of sinus venosus. The right horn of sinus venosus will give rise to smooth part of right atrium, while the left horn of the sinus venosus will give rise to the coronary sinus. As you can see in the picture, that the left horn has given rise to coronary sinus, while the right horn has given rise to the smooth part of right atrium. Here we have inferior vena cava and the superior vena cava. Okay, cardinal veins. The cardinal veins from superior vena cava and inferior vena cava, not from the heart, okay, connect to the right atrium. So the cardinal veins are coming directly from the superior or inferior vena cava, not from the heart tube, and they connect to the right atrium. Superior vena cava, I was wrong, I'm sorry. The cardinal veins are responsible for the formation of superior vena cava and inferior vena cava, which are connected to the right atrium. Superior vena cava coming from the right common cardinal vein and right anterior cardinal vein. Common cardinal vein is over here and the anterior cardinal vein is over here. So the superior vena cava will come from the right counterparts of anterior and common cardinal veins, while the inferior vena cava will come from posterior subcardinal and the supracardinal veins. Posterior subcardinal vein, the subcardinal vein. Okay, so posterior subcardinal and supracardinal veins will give rise to inferior vena cava, while the superior vena cava is coming from the right common and anterior cardinal veins. Venous system of developing embryo contains of three venous systems. First one is Wittline veins, then umbilical veins, and the cardinal veins. The Wittline veins of the portal system, umbilical veins degenerate, and the cardinal vein give rise to the veins of systemic circulation, for example, the superior vena cava. Okay, so the Wittline veins, they will give rise to the veins of the portal system. Got it? The cardinal veins will give rise to the systemic venous system, that is superior vena cava and inferior vena cava, while the umbilical veins, which are present over here, which are the main source of oxygen and nutrition for the child, for the fetus, they will degenerate over here. These umbilical veins and even umbilical artery, they undergo degeneration. Heart morphogenesis. The first functional organ in the vertebrate embryo is the heart. Okay, it beats spontaneously by week 4 of development. Cardiac looping. How does that take place? The primary heart tube loops to establish right and left-right polarity between week 4 of gestation. And okay, so the cardiac looping begins in the week 4 of gestation, establishes left-right orientation in the chest, requires cilia and dynein. That is very important, that cilia and dynein are required in the people who have primary ciliary dyskinesia. For example, the people who have Cartagena syndrome, they have dextrocardia because of lack of left-right orientation. Defect in the left-right dynein involving the left-right asymmetry can lead to dextrocardia, as seen in the patient with Cartagena syndrome, primary ciliary dyskinesia. Or 20 days, the endocardial tubes are looking like this. There are two endocardial tubes. On 21 days, fusion into the primitive heart tube. Okay. Then we have on 22 days, the truncus arteriosus is formed, which is going to give rise to the pulmonary artery and the ascending aorta. Then bulbus cordis, which is going to form the smooth part of the right and left ventricle. The primitive ventricles, the trabeculated part of both the ventricles will be formed by that, and the primitive atrium, which will form the trabeculated part of both the atria. Now we have truncus arteriosus, the bulbus cordis. Now you can see the rotation. It is rotating in a clockwise, no, anti-clockwise fashion, like this in this direction. So firstly, this rotation will occur. Then the ventricle, atrium, and sinus venosus will look like this, and ultimately, this is the configuration that will be attained. That aortic arch arteries will come out like there's 6 aortic arches and 6 aortic arch arteries, truncus arteriosus, left atrium, ventricle. On 35th days, the heart looks something like this. Okay. Moving forward, we'll talk about septation of the chamber. Atrial septation. It is very high yield concept. So remember this one. Septum primum grows towards the endocardial cushions, narrowing the foramen primum. So septum primum is this structure, the blue structure. Okay. So these the green things are endocardial cushions, which are derived from the neural crest cells. So these septum primum will come and it will start going towards the endocardial cushion, narrowing the foramen primum. The foramen primum is basically this opening between the right atrium and between the primitive right atrium and left atrium. This opening is called as the foramen primum. So the septum primum starts moving towards the endocardial cushion and narrows that. The foramen secundum forms in the septum primum. Foramen primum disappears. That is very, very important. That this is foramen primum. In the long run, what happens? Let's suppose this is the heart, and here we have endocardial cushions over here. Alright. So endocardial cushion looks something like that. The upper part of the and this opening between the right atrium and the left atrium, that is called the septum primum. Now we're talking about the atria. Now this opening, this septum starts moving downwards and that covers the whole layer, but there is an opening that is left inside this atrium, and that opening is called as septum secundum. So septum secundum appears inside the septum primum. The foramen primum is vanished, it disappears, and a secondary secundum is formed in the septum primum that causes the obliteration of foramen primum. So make a concept out of that. So foramen secundum forms in the septum primum. Foramen primum disappears. Septum secundum develops as a foramen secundum maintains as foramen secundum maintains the right to left shunt in the foramen. Okay. Now this is septum secundum. In front of septum secundum, and other septum starts descending downwards, and this septum will descend, but it will maintain this foramen. The foramen secundum is patent, although the septum secundum has come in front of that. Now, the septum secundum develops as foramen secundum maintains right to left shunt. The septum secundum expands and covers most of the foramen secundum. The residual foramen is the foramen ovale. Remaining portion of the septum primum forms valve as foramen ovale. Okay, so the remaining portion of the septum primum will form the valve of the foramen ovale. Septum secundum and septum primum fuses to form the atrial septum. Foramen ovale usually closes soon after birth because of the left atrial pressure. Now left atrial pressure is increasing. Normally the pressure in the fetal circulation is moving from the right to the left because the right atrium is a higher pressure system. But as soon as the lung expand and the blood start coming from the lungs into the left atrium, so the left atrial pressure increases in comparison to this one. So this closes the left atrium, and resultantly we get the closure of the foramen ovale. Okay, so here you can see that septum primum fuses the endocardial cushion. So septum primum has fused all the way with the endocardial cushion, and a secondary foramen is formed that is called as foramen secundum. Now this foramen secundum, in front of the foramen secundum and other septum starts descending downwards, that is called as septum secundum. Now this septum secundum will keep the foramen secundum patent, and there will be a right to left shunting in the fetal circulation. As soon as the left atrial pressure increases, so this septum secundum will go, and so this septum primum, which is acting as a valve, that will go and attach firmly with the septum secundum. So both these septums fuse together, and the foramen ovale is closed. Okay. Now moving forward to this picture, here you can see atrial septation. So let me zoom it in. I guess it is a picture from the Uworld. So this is septum primum with ostium primum and endocardial cushion. Septum primum is started descending, and the ostium primum is already present. the septum primum is descending all the way to the endocardial cushion, and the secondary ostia has started forming inside the septum primum, that is called as ostium secundum, and the secondary septum or septum secundum is also started descending downwards. Now here you can see that there is an opening in the septum secundum which is communicating with the septum secundum, which is open. I'm sorry. There is an opening in the septum secundum which is communicating with the foramen or ostium secundum. This opening is called as foramen of veil. From this foramen of veil, the blood will pass and then to the ostium secundum into the left atrium. As soon as the left atrial pressure increases after the birth of the fetus, the whole system reverses, and the septum primum will go and fuse with the septum secundum, and the foramen of veil is closed. Okay, and this becomes fossa ovalis in the adult heart. Okay, then we have patent foramen of veil. The patent foramen of veil is caused by the failure of septum primum and septum secundum to fuse together after birth. Consider normal variant of in the adults, like 20 to 30% of the people have normally patent foramen of veil. Most are left untreated, and the people are also asymptomatic. Can lead to paradoxical emboli, venous thromboemboli that enter the systemic circulation, similar to those resulting from the ASD. Now, what happens in this, that normally if there is, if this is the heart, okay, suppose this is the heart with a patent foramen of veil. Normally, if there was some thrombus in the deep veins of the leg and DVT was there was dislodgement of that thrombus, and the embolus came all the way from the legs into the inferior vena cava, into the right atrium, then to the right ventricle. It was supposed to go to the pulmonary circulation, and then due to the deep vein thrombosis, we can get pulmonary emboli normally. But in this case, because of the patent foramen of veil or atrial septal defect, this embolus that was coming the right atrium, that can go to the left atrium and then to the left ventricle, all the way to the systemic circulation and even to the brain. Now, this concept of venous emboli lodging into the brain is called as paradoxical embolization, because it is not possible in the normal situations. If it happens, so this means that the person is having a patent foramen of veil or ASD. Okay, so it remains closed as the pressure in the left atrium is usually more than right atrium. So increased right atrial pressure, right to left shunt, and hypoxemia. Normally, even if it is patent, the pressure in the left atrium is so high in comparison to the right atrium that there is a tethering force that is joining the two septums together, the septum primum and secundum, and the foramen of veil, even though it is patent, it does not functionally work to transfer the blood from the right atrium to the left atrium. But in the conditions when the left atrial pressure drops down, in those situations the blood can move from the right atrium to the left atrium, and that will result in hypoxemia. Now, this is the foramen of veil, the normal mechanism. Foramen of veil allows the partially oxygenated blood to flow between the atria by passing the lungs. Okay, increased left atrial pressure, so this is before birth, that the right atrial blood is shunted into the left atrium. But after birth, the left atrial pressure increases and the right heart pressure decreases, and decreased pulmonary vascular resistance result in the thin septum primum being pushed against the thick septum primum. So the reason of decreasing the right atrial pressure, or the decreasing pressure on the right heart and the increasing pressure in the left heart, is same, that the lungs have started increasing in size, and when the lungs increase in size, the pulmonary vascular resistance has decreased. If the pulmonary vascular resistance has decreased, the pressure that was exerted by the right ventricle to push the blood into the lungs has also decreased. Resultantly, the right heart pressure is decreased. The pressure in this right heart is decreased because now less force is required to push the blood into the lungs. Secondly, since the lungs are expanding, more and more blood will go into the lungs and then into the left atrium. Resultantly, due to the entry of more amount of blood, the left atrial, or the left half of the heart pressure increases. So the pressure in the left heart is increasing. Resultantly, this will exert a force on this septum primum to fuse with the septum secundum, and the foramen of veil is closed. So this is the normal physiological mechanism. Now let's move to the septations of the ventricles. So the ventricular septum has two components. First one is the muscular component, and second one is the membranous component. The muscular ventricular septum forms opening is called as the interventricular foramen. Aorticopulmonary septum rotates and fuses with the muscular ventricular septum to form the membranous interventricular septum, closing the interventricular foramen. Now the thing that is happening here, you can see that this is muscular ventricular septum that grows towards the endocardial cushions, right? Then we have atrioventricular canals. These are atrioventricular canals. The connection between the atrium and the ventricle is simply called as atrioventricular canal. This is not a very big thing. So atrioventricular canal, this thing that is called as the truncus arteriosus. The truncus arteriosus has a septum that rotates inside the truncus arteriosus to cause the splitting of the truncus arteriosus into pulmonary artery that is connected to the right heart and the aorta that is connected to the left heart. Now, this splitting of this septum, or this aorticopulmonary septum that is rotating inside the truncus arteriosus, this will give the membranous segment of the interventricular septum. Yeah. So this membranous segment, the membranous ventricular septum, is now connected to the muscular septum, and the interventricular foramen is closed. Okay. Aorticopulmonary septum rotates and fuses with the muscular ventricular septum to form the membranous interventricular septum, closing the interventricular foramen. Growth of the endocardial cushion separates the atria from the ventricles and contribute to both the atrial septation and membranous portion of the interventricular septum. Ventricular septum pathology. Membranous VSD, most common type, and muscular VSD can also occur. So if there is pathology with the membranous part of the interventricular septum, that is most common, this will cause membranous VSD, but muscular VSD can also occur if there is some defect in this place. Okay. So this, we have studied this one. Now let's move over to the endocardial cushion. What is the endocardial cushion? They contribute to several cardiac structures, like atrial septum is coming from the endocardial cushion, ventricular septum, AV valves, mitral and tricuspid valve, and semilunar or aortic or pulmonary valves. Endocardial cushion defects: atrioventricular canal defects, atrioventricular septal defects, ASD, VSD, and valvular malformations, common in Down syndrome. Okay, so in the Down syndrome, we have this kind of heart. This is TAP, total anomalous. Let me see the name of that. I was talking about TAP VR. This is not TAP VR. This one is, like, here you can see that there is a common atrioventricular canal and congenital mitral regurgitation plus ostium primum ASD, that leads to endocardial cushion defect, and mostly with the Down syndrome. And here you can see that there is a common atrioventricular valve. Left atrium is over here. This is right atrium, right ventricle, left ventricle, and ASD, VSD both are present, like atrial septal defect and ventricular septal defect. And there is a common valve that is connecting, or that is separating, the atria from the ventricles. So this is a condition that is common in the Down syndrome. I guess there is some name to this condition, and that will come in the pathology section. So let's move forward. Aorticopulmonary septum. The aorticopulmonary septum formed by the neural crest cells. Okay, so aorticopulmonary septum is coming from the neural crest cells. Formation of the truncal and bulbar ridges that spiral and fuse to form the aorticopulmonary septum. Separates aorta and pulmonary arteries. Fuses with the interventricular septum. They fuse with the interventricular septum to form the membranous part of the interventricular septum. So this is kind of a confusing diagram, because I guess this is the best way to remember this thing is to see an animation. So kindly check an animation. All the animations are pretty good. So check some animation on the on the YouTube. But let's see it over here. Formation of the aorta and pulmonary trunk and interventricular septum. So here you can see that we have the truncus arteriosus. So here you can see truncus arteriosus. So the truncus arteriosus, the ridges appear at the opposite side of the truncal lumen. Okay, so the ridges appear at opposite sides of the truncal lumen. The truncal ridges grow towards each other, so they are going towards each other, and then they are rotating all the way, like they were facing each other over here. Then they moved 90 degrees over here, then more than 90 degrees or something. I don't know. Okay, so the cells at the ventricle base grow towards the endocardial cushion and form the muscular part of the interventricular septum. Here you can see that the muscular part of the interventricular septum is being formed by the cells at the ventricular base, which grow towards the endocardial cushion, and spiraling of the aorticopulmonary septum result in the pulmonary trunk anterior to the aorta. So remember that the pulmonary trunk is residing anterior to the aorta, and the septum will fuse with the muscular part of the interventricular septum to form the membranous part of the interventricular septum. Abnormal aorticopulmonary septum, that is called as conotruncal abnormalities. It can result in transposition of great vessels, which is failure to spiral, which means that septation is complete, but these arteries did not spiral properly. That is, pulmonary artery is connected with the pulmonary artery is connected with the left ventricle, and the aorta is connected to the right ventricle. Tetralogy of palate, skewed septum development, anteroposterior displacement of the septum, and abnormal neural crest cell migration. Persistent truncus arteriosus, partial incomplete septum development. Okay, then we'll talk about valve development. Aortic pulmonary, derived from the endocardial cushion of the outflow tract. Mitral or tricuspid, derived from the fused endocardial cushion of the AV canal. The valvular anomalies may be stenotic, regurgitant, atratic. Okay, for example, tricuspid atresia or displaced, that is seen in the Epstein anomaly. Okay, Epstein anomaly is the atrialization of the right ventricle. In that case, the tricuspid valve, which is present on the right side of the heart, suppose there is the right side of the heart, So the tricuspid valve, which should normally be present over here, is displaced all the way downward into the ventricle, and that is called as atrialization of the right ventricle. It comes over here, and since it is now present in a more wide space, so it also becomes regurgitant. So this is called as Epstein anomaly. Okay, that is associated with lead intoxication during intrauterine life. Okay, uh, then we have shunts. So left sided pressure is more than the right sided pressure. Shunts are normally left to right shunts. Most common example of the left to right shunt in an adult, in a in the adult population, if there is some patent foramen, or if there is patent connection between the ventricles and atrium because of some septal defects. So the shunts that develop are from the right to the left side of the heart. I'm sorry, I mess these things always. In the adults, if there is some patent septum defects, so resultantly there will be left to right shunting in the adults. Okay, in adults we see left to right shunting. The VSD, left to right shunt from left ventricle to right ventricle, ASD, left atrium to right atrium, and patent ductus arteriosus, aorta, which is a component of the left heart circulation, to the left pulmonary artery, which is a component of the right heart circulation. At birth, the left to right flow, volume overload of the right heart, blood flow to the lungs is unimpaired, and there will be no cyanosis. At birth, left to right flow, volume overload of the right heart, blood flow to the lungs unimpaired, and there is no cyanosis. So in the case of non-cyanotic conditions, what happens is that the blood flow from the left to right heart is happening, but since the blood that is entering the right heart is going all the way to the lungs and back to the left heart, so that thing is not going to cause any kind of cyanosis early on. Like at birth, the patient will be acyanotic. Years later, if it is untreated, the pulmonary vessels become stiff and thick because they have to suffer a lot of unnecessary stress which normal people do not have to. Right ventricle hypertrophies, the right sided pressure rises, and shunt reverses. That is called as Eisenmenger syndrome, that now the normal shunt that was left to right has converted into right to left shunt. Cyanosis occurs when Eisenmenger syndrome occurs. These are called blue kids or blue babies. Suppose that this is the, I'm drawing the two ventricles. This is the interventricular defect. There is patent ventricular foramen, and through this ventricular wall defect, ventricular septal defect, the blood from the left ventricle is coming to the right ventricle. Why so? Because we know that the systolic pressure in the left ventricle is 120, while in the right ventricle it is like some 25, maybe. I guess it is 25, something on those lines. So 120 and 25. So the pressure is very, very high on the left side. That is why the blood is moving to the right side. Got it? Now, due to constant, persistent, chronically patent ventricular septal defect, in which the blood is constantly being moving towards the right side, the right side started undergoing hypertrophy. It hypertrophies so much. Firstly, it will undergo hypertrophy. Secondly, the pulmonary artery valves, or the pulmonary artery which is connected to the right heart, that also become irritated, that also become agitated and hypertrophies, and the valve becomes stenotic. Now, firstly, it itself is becoming hypertrophied. Secondly, there is increased afterload for the right heart, so the ultimate pressure may become 125. That is, it is increasing consistently or persistently, that causes the pressure to rise more than the left ventricle. So the shunt that was normally left to right becomes right to left, and this phenomenon is called as Eisenmenger syndrome. Now moving forward to the next thing, that is congenital heart diseases. The congenital heart diseases can either be cyanotic or non-cyanotic. The cyanotic are 5 T's, that is truncus arteriosus, the transposition, which is 2 switched vessels, tricuspid atresia, okay, tetralogy of Pallet, and TAP VR, that is total anomalous pulmonary venous return. We'll see all of them one by one when we do the pathology section. So truncus arteriosus, like you can remember them 1, 2, 3, 4, 5. How? Truncus arteriosus, there is only one vessel. Normally we are supposed to have two vessels, anterior one the pulmonary artery, and the posterior one the aorta. The aorta must, because both of these arteries are coming and originating from the division or splitting of the truncus arteriosus. But in the case of patent truncus arteriosus, there is no splitting and we have only one vessel. In transposition, we have two switched vessels, like the pulmonary artery is now connected to the left ventricle, and the aorta is connected to the right ventricle. Tricuspid atresia, 3 for tri and 3 for, okay, this is number 3 cyanotic condition. Number 4 is tetralogy of Pallet. They have 4 problems. And TAP VR, they are 5 letters, T, A, P, V, R. They are 5 letters in the name, so it is the 5th. So we can remember the numerals 1, 2, 3, 4, 5, and this is the mnemonic for the cyanotic heart diseases. For the non-cyanotic, remember it is ASD, VSD, patent ductus arteriosus, and coarctation of aorta. Right to left shunt cyanotic heart diseases. Early cyanosis, which are called blue babies, often diagnosed prenatally or become evident immediately after birth, usually require urgent surgical treatment and or maintenance of the patent ductus arteriosus. Okay, so in the case of blue babies, the people who are having cyanotic heart disease often diagnosed prenatally or become evident immediately after birth, and we have to make the patent ductus arteriosus patent, because that is the only source of blood, that is the only source of oxygenation of the systemic circulation, because the blood that is entering the right heart needs to go to the left circulation because there are a lot of conditions over here. Suppose we have we have transposition of great vessels. So now in the transposition of great vessels, suppose I'm talking about transposition. So the pulmonary artery is connected to the left ventricle and the aorta is connected to the right ventricle. Now there are two independent circuits going on. That the right ventricle pumps the blood into the lungs, which comes back to the left atrium, and then left ventricle, and again that blood is pumped to the lungs and all that. The right ventricle is pumping the blood to the systemic circulation, which comes back to the vena cava, back to the right atrium, right ventricle, and then again to the systemic circulation. So these are two independent circuits which are not communicating with each other at all. To make the communication, we have to make the patent ductus arteriosus, which is present over here, patent, so that the oxygenation of the blood that was happening in this section should go to the right and systemic circulation and stuff like that. So patent ductus arteriosus, or any sort of connection between the right or left heart, is very important in the case the person is having cyanotic heart diseases. Persistent truncus arteriosus. The truncus arteriosus fails to divide into pulmonary trunk and aorta due to lack of aorticopulmonary septum formation. Aorticopulmonary septum is a neural crest cell derivative. Most patients have accompanying VSD in the case of patent truncus arteriosus, persistent truncus arteriosus. So here you can see a persistent truncus arteriosus. Pardon me, actually I was trying to teach something else. Okay, so here you can see that this is the aorta and pulmonary artery, and both of them are on the base are connected to both the ventricles. So there is VSD, and along with that there is a common trunk that is going to form aorta as well as the pulmonary artery. So the blood is going to the common trunk and then moving to the certain directions. So that is why it is a cyanotic condition. Truncus arteriosus over here, then ventricular septal defect, and then we have the ventricles. CVS system, the transposition of great vessels. I was talking about this condition. So transposition of great vessel due to the failure of aorticopulmonary septum to spiral. Aorta leaves the right ventricle anterior and pulmonary trunk leaves the left ventricle, which is posterior. It is a normal position. No, it's not normal. Normally the pulmonary artery needs to be anterior, but in the case of transposition of great vessel, the aorta leaves the right ventricle, that is placed anteriorly now, and the pulmonary trunk leaves the left ventricle, that is posteriorly placed. Separation of the systemic circulation and the pulmonary circulations. It is not compatible with life unless a shunt is placed to allow the mixing of blood, that is VSD, patent ductus arteriosus, or the patent foramen ovale. Without surgical intervention, most infants die within the first few months of life. High incidence of infants of diabetic mothers. Transposition of great vessels. So here you can see the normal heart. The pulmonary artery is anterior to the aorta. Aorta is originating from the left ventricle, and the pulmonary artery from the right ventricle. Here you can see that the aorta has come anterior to the pulmonary artery. Now the aorta is coming from the right ventricle and the pulmonary artery is coming from the left ventricle, and we need to have a patent ductus arteriosus or an ASD or a VSD or some sort of connection between the two circulations to maintain the connection or to mix the oxygenated blood with the deoxygenated blood. Otherwise this condition is not visible for the life, is not fit. These children are not viable for life. Okay, tricuspid atresia. Absence of tricuspid valve and hypoplastic right ventricle. So we will have a hypoplastic right ventricle, and there will be total absence of the valve. Okay, here you can see that this is a slit that is separating the right atrium from the right ventricle, and there is no opening in that slit, so that is why it is tricuspid atresia. It requires both ASD and VSD for the viability. So in this circulation, the superior vena cava and inferior vena cava will drain into the right atrium. From there, the blood will go through the ASD into the left atrium, then to the left ventricle, and then back to the right ventricle for going into the lungs, and then after going to the lungs, the blood will come back to the left atrium, to the left ventricle, and to the aorta. So if these children are to be viable for life, so they have to have both the ASD as well as the VSD. So this is opening of the ASD and absent tricuspid valve, or you may say atretic tricuspid valve. Okay, opening between the ventricles, VSD, and underdeveloped right ventricle. What is tetralogy of Fallot? It is very important condition. There are 4 things which you must never forget about this thing. So the components are the pulmonary infundibular stenosis, right ventricular hypertrophy, overriding aorta, and VSD. Will come back to them. Now let's talk about this thing caused by anterosuperior displacement of the infundibular septum. The infundibular septum, what's that? Infundibular septum. Most common cause of early childhood cyanosis, anterosuperior displacement of the infundibular septum. I have to see that. Infundibular septum. Anterosuperior, yeah. All that. What is infundibular septum basically? So the infundibular septum is the muscular structure interposed between the two semilunar valves on the ventricular side. So semilunar valves are the present in the aortic and the pulmonary artery. So the septum that is present between these valves is called as the infundibular septum. Its length was measured from the aortic valve to its free border in the TGA. And from what's transposition of great arteries? I'll forget about that. So it is the septum between the two semilunar valves. Okay, so the anterior superior displacement of this septum, all the feature of tautology of Fallot from the anterior Fallot result from the anterior superior displacement of the infundibular septum, leading to the abnormal septation between the pulmonary trunk and the aortic root, right ventricular hypertrophy. Okay, so basically it is because of lack of septation between the pulmonary trunk and the aortic root. Coming back to the discussion. So here we are saying that it is caused by the anterior superior displacement of the infundibular septum. Most common cause of early childhood cyanosis. Pathophysiology: septum is displaced, move towards the right ventricle. Okay, so if the septum is displaced and it is moved towards the right ventricle, so the aorta will be overriding. Causes overriding of the aorta. 5 to 95% of the aorta may lie over the right ventricle. So suppose that we have the VSD, like it looks something like this. It is VSD, and aorta was supposed to look something like that, but because septum is not present, septum is actually present but displaced, so because of that aorta looks something like this. It is overriding the ventricular septal defect and it is present over both the arteries, both the ventricles, and in some cases it may be present on the right ventricle, but it is not something like transposition of great arteries because there is ventricular septal defect and both the ventricles can push their blood into the aorta. Causes VSD, usually larger and non-restrictive. Okay, infundibulum, conus arteriosus, funnel leading to the pulmonic valve. Okay, so conus arteriosus is basically the funnel that is leading to the pulmonic valve. That is infundibulum. It develops on the bulbus cordis. Smooth muscular structure of the right ventricle, outflow to the pulmonary artery. So this is normal physiology, bro. Infundibulum, conus arteriosus, funnel that is leading to the pulmonic valve, and development from the bulbus cordis. Smooth muscular structure of the right ventricle, outflow to the pulmonary artery. Okay, so what happens when the infundibular stenosis occurs? Subpulmonary stenosis, right ventricle outflow tract is obstructed. Abnormal pulmonary valve, rarely main cause of obstruction, and flow obstruction to the right ventricle, that will lead to right ventricular hypertrophy. Remember that the second option. Let's read this point. The abnormal pulmonary valve, suppose this is the pulmonary artery and there is the semilunar valve for the pulmonary artery. It does not look like that. Maybe this is the pulmonary valve. Okay, this is the semilunar valve, something like that. The problem with the semilunar valve is one of the rare causes of the minor causes of tetralogy of Fallot. The main cause is the infundibular stenosis, not the valvular stenosis. Abnormal pulmonary valve, rarely main cause of obstruction. The actual problem is subpulmonary stenosis, that stenosis below that, over here somewhere. Right ventricular outflow tract obstruction, and when the right ventricular outflow tract is obstructed, resultantly the right ventricular hypertrophy takes place. Components of the tetralogy of Fallot are 4. Number 1 is pulmonary infundibular stenosis, the one which we just studied. Most important determinant of prognosis. Pulmonary stenosis forces the right to left flow across the ventricular septal defect, because suppose that this is the heart and this is the ventricular septum and there is ventricular septal defect and the pulmonary artery is originating like that and there is some stenosis over there. So pulmonary artery stenosis is happening. So instead of going in that direction, the blood will take the easier or the path with least resistance and go to the from the right ventricle to the left ventricle. So the pulmonary stenosis forces the right to left flow across the VSD. That also results in right ventricular hypertrophy, and that results in TET spells, often caused by crying, fever, and exercise due to exacerbation of the right ventricular outflow obstruction. Okay, so anything that can exacerbate the right ventricular outflow tract obstruction will cause the shunting of the blood from the right ventricle to the left ventricle. The right ventricular hypertrophy, boot shaped heart, okay, that is very important. They may give you the x-ray, or they may give you this thing in the question stem that the person has developed boot shaped heart. So boot shaped heart in the chest x-ray is found in the tetralogy of Fallot, overriding aorta and ventricular septal defect. Squatting, increased stroke. Okay, so squatting is going to relieve the TET spells. Squatting is a position in which you do squats like this and this, and so this is a squatting position. The squatting position increase systemic vascular resistance, decrease the right to left pulmonary shunt, improve the cyanosis. So if we, now the problem was that the resistance of the pulmonary artery was so high that the blood from the right heart started moving to the left side, right? Because this was the area of least resistance. Now if we increase the systemic vascular resistance, that is the outflow obstruction, the resistance to the outflow of blood from the left ventricle, so the left ventricular pressure will increase and this pathway will become more resistant than this one. So resultantly, what do we find is more and more blood starts flowing into the pulmonary artery. So everything is going relative. Firstly, there was a relatively high resistance in the pulmonary circulation, so the blood started moving to left. Now if there is relatively high resistance in the left circulation, so the blood will start moving to the pulmonary artery. So this is relative things going on over here. Treatment is early surgical correction. So here you can see normal heart, and this is tetralogy of Fallot. So there are 4 things. Number 1, right ventricular hypertrophy. Okay, so don't start it from here. There will be ventricular septal defect. Okay, so the first thing, as you can remember it, pulmonary stenosis, that leads to right ventricular hypertrophy, that has a concomitant ventricular septal defect, due to which we have an overriding aorta. I remember it like that. You may make your own sequence. Boot shaped heart, adults with right ventricular hypertrophy and infants with T4. What's T4? T4, tetralogy of Fallot. Oh, okay. So adults who have right ventricular hypertrophy, for example, the person who has developed pulmonary stenosis or pulmonary hypertension, and due to any reason, because maybe there is that disease that is called as restrictive lung disease of any sort, like IPF, in interstitial idiopathic pulmonary fibrosis. Okay, for example, the person has developed idiopathic pulmonary fibrosis, he may develop right ventricular hypertrophy, and that will look like a boot shaped heart in an adult, and in the children it is because of tetralogy of Fallot. Here you can see a boot shaped heart like this, and this is a boot. So here you can see it. Then total anomalous pulmonary venous return. So in this condition, pulmonary veins drain into the right heart circulation. They are draining directly into the right heart. Superior vena cava, coronary sinus, etc., associated with the ASD and sometimes a patent ductus arteriosus, to allow the right to left shunting to maintain the cardiac output. So in the total anomalous pulmonary venous return, here the pulmonary veins, instead of entering the left atrium, they are going into the superior vena cava or maybe into the right atrium, and from there we require an ASD or PDA to maintain the blood flow, the oxygenated blood, to flow back into the left atrium so that it can get circulated into the systemic circulation. So anomalous pulmonary venous drainage into the superior vena cava, here you can see it. To cause the blood to flow back to the left atrium, we need an atrial septal defect. Then we have right atrium. This is right ventricle, left atrium, pulmonary veins, pulmonary artery, and aorta. Then talking about Epstein anomaly, it is characterized by the displacement of tricuspid valve. Tricuspid valve leaflets downward into the right ventricle artificially, atrializing the ventricle. Can be caused by lithium exposure in utero. The clinical presentation is tricuspid resurge. Okay, tricuspid regurg, because now it is in the narrower space. If it moves downwards, so it enters that wider space, so that the cusp of the leaflet do not face each other, do not meet each other. So there is a probability of tricuspid or tricuspid regurgitation. Right-sided heart failure, dilated right atrium increase the risk of supraventricular tachycardia. Vasodilated right atrium, if the right atrium becomes dilated or bigger, so this will increase the risk of supraventricular tachycardia, because the concept is that if the cardiac impulses they reach the starting point, and the starting point was still in the depolarizing stage, so this impulse dies out. But if the right atrial diameter is increased to this extent, that the impulse that is circulating in the atrium, before it reaches back to the point of origin, this area has come out of depolarization. So this impulse will generate a new impulse, and this vicious cycle will continue, and this will make the arrhythmia to circulate throughout the atrium. So this is the concept. So increasing the diameter will increase the length or distance that an impulse has to cover, and that will increase the chance of development of supraventricular tachycardia. Accessory conduction pathway, for example, Wolff Parkinson White syndrome. Okay, so the clinical presentation of tricuspid regurgitation, dilated right atrium with supraventricular tachycardia, or accessory conduction pathway, for example, Wolff Parkinson White syndrome. All of these conditions can be present in such scenario. Then we have a complete AV canal defect. In the complete AV canal defect, the AV canal contributes to the formation of AV valves, that is mitral and tricuspid valves, and the AV septum. So atrioventricular canal leads to the formation of AV valves, that is mitral and tricuspid valves, and the atrioventricular septum. Complete absence, that is single common atrioventricular valve. Okay, so this was the condition, single common atrioventricular valve, which was seen in the Down syndrome. So the single common atrioventricular valve, which is often associated with the regurgitation and strong association with the Down syndrome, complete AV canal defect. Okay, so here you can see there is a common atrioventricular valve connecting all the four chambers together. Both the atria are connected to both the ventricles. Ventricular septal defect is also present. Then left ventricle is over here. Right ventricle atrial septal defect. Okay, so atrial septal defect along with the ventricular septal defect with a common atrial valve. This is a strong association with the patient of the Down syndrome. So here you can see the common AV canal. The mitral valve and tricuspid valve are just one. There is only one valve for both of these things. So there is fusion of these two valves, you may say that, and single atrioventricular valve is present. The right to left shunts, acyanotic heart diseases. So the diseases which we just discussed are which they were left to right shunt, and no, the diseases which we just ended discussing, they were right to left shunt of cyanotic conditions. Number one, truncus arteriosus. Number two, number two was something else. Transposition of great arteries. Yeah, transposition of great arteries. Number three, it was tricuspid atresia. Number four was tetralogy of palate, and number five was TAPVR, TAPVR, and number six was common AV canal. I'm sorry, this is number six, the common AV canal. That's number seven. What's number six? Okay, I've seen anomaly is number six, and number seven is common AV canal. The important five are these. Okay, now let's move forward to the right to left shunt, which are acyanotic heart diseases. The child at birth is totally asymptomatic. Acyanotic at presentation, cyanosis may occur years later. Right to left shunt, early cyanosis, and left to right shunt, later cyanosis. Remember these things. Ventricular septal defect, most common congenital anomaly. Ventricular septal defect is the most common congenital anomaly. Communication of left ventricle to right ventricle, harsh hollow systolic murmur. There is a harsh hollow systolic murmur. Tricuspid at the tricuspid area, that is left lower sternal border. Tricuspid area is at the left lower sternal border, in the fourth or fifth intercostal space, maybe at the left lower sternal border, and this will be harsh hollow systolic murmur. I will highly recommend all of you to listen to the sketchy pathology for this one, because after listening to that pathology, the concept of which murmur is present in which disease becomes very easy for you. So that is how I remember that. But there are some Uworld tables which we will discuss in this session. They will also make the concept easier. Okay, so the harsh hollow systolic murmur is present. Hollow systolic means throughout the systole, that is between S1 and S2 sounds. Throughout that we hear this sound. O2 saturation increases in right ventricle and pulmonary artery. Okay, in the right ventricle as well as the pulmonary artery, because the blood is moving from the left ventricle, that is oxygenated blood from the left ventricle is moving to the right ventricle. So the oxygen saturation in the right ventricle and the pulmonary artery is increasing. It is characterized in many ways: size, location associated with the small VSD, which resists the flow across the defect, that is destructive, lots of turbulence, and it will be a loud murmur. So for the small VSD, we'll hear a loud murmur, and for the large VSD, the murmur will be small, like the audibility or the sound or the intensity of the murmur will be lowered if the VSD is large. Large hole, that is non-destructive, significant shunting, may lead to left ventricular overload and heart failure, often closed surgically. Although it is going to produce a quiet murmur, even then there is significant shunting that is taking place. So this is very serious condition, and we need to cure it surgically as soon as possible. So this is the picture from the Uworld. In normal heart, the no, this is not a normal heart. Right ventricle, left ventricle. It is seen as the ventricular septal defect. So here you can see that the right atrium is having 75% oxygenation. The same amount of oxygenation should be present in the right ventricle, because there is no source of further oxygenation. But here the right ventricular oxygen content has stepped up, or 75%, it has become 86%, and the oxygen saturation in the right ventricle has increased in comparison to the right ventricle. Now this 86% become 86% over here, then from the lungs it become 96%, then 96% over here, and 96. So this anomalous increase in the oxygen is because of the ventricular septal defect, and they give you the diagram in the step exams like this. Then we have atrial septal defect, ASD, communication between the left and right atrium, add the volume to the right atrium and right ventricle. Types of murmur which are associated with the ASD: delays the closure of pulmonic valve, wide fixed splitting of S2. That is very important. That what is the site and what is the origin of murmur? In the case of ASD, although the problem is that both the atria are communicating with each other, the defect is lying over here, but this is not a site of production of murmur. Why is the murmur being produced? There is more and more blood that is shunted from the left atrium to the right atrium, due to which more blood is moving to the right ventricle, and due to more blood entering the right ventricle, more and more blood is moving through the pulmonary artery, and due to the increased amount of blood flow through the pulmonary artery, we hear the murmur. That is because it delays the closure of pulmonic valve. Normally in the S2 heart sound, because we have S1 sound, S1 heart sound is because of the closure of mitral and tricuspid valves, and S2 heart sound is because of closure of the aortic and the pulmonary valves, right? Now the S2 heart sound has two components, that is A2 and P2. So we'll see that those tables as well. These are the two sounds which are normally present in the S2 sound. So S2 sound has two components. One is the A2 which comes from the closure of the aortic valve, and then second one is the P2 that comes from the closure of pulmonary valve, right? So these two sounds normally they are heard as one sound, like there is only one sound that is heard on inspiration. Maybe there is some splitting, but that also resolves on expiration. Let me show you a picture of Uworld. I've just downloaded that. Okay, just give me a second. Okay, yeah, there's the picture. Yeah, if you can see in the picture, so during the inspiration, in the normal physiologic conditions, the P2 sound moves away from the A2 sound during inspiration, and that comes back during expiration. That is a normal finding. But even in the inspiration, if you are not a very pro doctor, you won't be able to listen the split. You won't be able to listen the split of S2 sound. It normally is one sound. But in the case of pathologic findings, the P2 sound is, firstly it is widely split, and secondly it is fixed splitting. That is, it is present both in inspiration as well as during expiration, and the situations that cause that are pulmonic stenosis, pulmonary hypertension, ASD, right bundle branch block, or early A2 with VSD. Okay, so we'll discuss that later on, but the point I wanted to highlight was that in the case of wide fixed splitting, we see in the case of pulmonary stenosis, okay, or in our case it was atrial septal defect. In the case of ASD, we find wide fixed splitting. So let's come back to our PDF over here. So there will be wide fixed splitting of S2, increased flow across the pulmonary valve and the tricuspid valve. Systolic ejection murmur will be heard, and rarely a mid-diastolic murmur can also be felt. That's a rare finding, but most of the time you find a wide and fixed splitting with the ASD. Oxygen saturation increases in the right atrium, right ventricle, and the pulmonary artery. May lead to paradoxical emboli. The systemic venous emboli used to bypass the lungs become the systemic arterial emboli. So ASD can cause paradoxical emboli, as we have previously discussed, that the DVT emboli which is coming from the lower limbs enter the inferior vena cava, then to the right atrium, the right ventricle, then instead of going to the pulmonary artery, if we have a patent foramen ovale or atrial septal defect, that may go directly into the left atrium, left ventricle, into the aorta, into the brain. So this is the right atrium. Okay, ASD is also evident over here. The left atrium is communicating directly with the right atrium. Okay, then we have secundum type of ASD, most common. Defects at the site of foramen ovale and ostium secundum, poor growth of septum secundum, or excessive absorption of the primary septum, located mid septum, and often isolated defect. It is septum secundum type of ASD, in which the problem is with the septum secundum, and that is most common, and defect at the site of foramen ovale ostium secundum. Okay, so here you can see the septum secundum type of ASD. This is the normal configuration with the patent foramen ovale. Foramen ovale is present between the septum secundum and the septum primum. It communicates with the foramen secundum like this. If the septum secundum is too short or septum primum is excessively reabsorbed, so in that case we have septum secundum type of ASD. Okay, defect at the site of foramen ovale ostium secundum, poor growth of septum secundum, or excessive absorption of the primary septum, located in the mid septum and often isolated defect. Patent foramen of veil versus ASD. Patent foramen of veil, failure of fusion of the septum primum and septum secundum. There is no abnormality in the growth or absorption of any septum. Like in here we can see that there is shunted growth of the septum secundum or increased absorption of septum primum. But in the case of patent foramen of veil, both the septum are normal. The only defect is that they are not fused together. That is patent foramen of veil. Secundum type ASD is defect in the primitive atrium. Okay, secundum ASD, secundum type ASD is a defect in the primary primitive atrium. Okay, what is primum type ASD? Failure of septum primum to fuse completely with the endocardial cushion leaves a persistent ostium. So now the problem is that this septum primum, which is fusing with the endocardial cushion over here is not fusing completely, and resultantly, if there is a picture of that, there is no picture of that. So the problem is that this septum, suppose it was over here, and the septum primum was to come all the way over here, it did not fuse, and that is how we have primum type of ASD. Located near the AV valve, the lower part of the interatrial septum, often occurs with other defects. These patients usually have cleft in the anterior leaflet of the mitral valve. They have a cleft in the anterior leaflet of the mitral valve as well as in the septal leaflet of the tricuspid valve. So the problem is that they have primum ASD. Along with that, there will be a cleft in the anterior leaflet of the mitral valve as well as a septal leaflet of the tricuspid valve, causing the regurgitation through the AV valves. Both the AV valves, that is mitral and tricuspid, will have regurgitation, and this is seen in the endocardial cushion defect in the Down syndrome. So this is the defect which we see in this condition, that is common complete AV canal defect. So here you can see that the septum primum that was to come down and fuse with the endocardial cushion that was supposed to be present over here is not fusing with it. Along with that, there may be septal defect, and we find a common AV valve. So the common AV valve can be present, and this may be seen in association with the primum type of ASD. Then we have patent ductus arteriosus. We will discuss the patent ductus arteriosus in the next session. Until then, Allah Hafiz, fi manillah, and take care. Okay.